Good afternoon, everyone. I'm Tamiko Brown-Nagin, Dean of the Radcliffe Institute for Advanced Study at Harvard University. I'm pleased to welcome you to the latest installment in our virtual Radcliffe discussion series exploring health equity in the time of COVID-19. As I previously mentioned, this series reflects three critical elements of the Institute's mission. First, it reflects Radcliffe's commitment to address pressing issues facing our society, a commitment at the center of our strategic plan, Radcliffe Engaged. Second, it reflects our commitment to cross-disciplinary research and our conviction that insights from across academic disciplines can advance public discourse and discern innovative solutions to complex problems. Third, and finally, this series reflects the Institute's commitment to equity and opportunity. We know that COVID-19 is disproportionately affecting vulnerable and marginalized communities. Together, we have a responsibility to examine the harms that this crisis has revealed and exacerbated, and to help chart a more equitable way forward. This discussion is a part of that important effort. Today, we turn our attention to the question of what comes next. What should the new normal look like when this crisis subsides? How can we improve a public health and social infrastructure that has shown itself to be woefully inadequate to the task at hand? Crisis presents opportunities. Throughout history, moments of crisis have forced us to reevaluate assumptions and policies. As we bear witness to the devastating impacts of COVID-19, we must pursue a more responsive, sustainable, and equitable public health infrastructure. This afternoon's expert panel will help us envision that way forward. I'm grateful to each of our distinguished panelists for joining us. María Belén Power is Associate Executive Director of GreenRoots, an organization in Chelsea, Massachusetts that pursues environmental justice and improved public health through youth empowerment, community engagement, and community organizing. Dan Carpenter is Faculty Director of the Social Sciences Program here at Radcliffe and the Allie S. Professor of Government in Harvard's Faculty of Arts and Sciences. And Sara Bleich is the Carol K. Pforzheimer Professor and Social Sciences Advisor at Radcliffe, as well as Professor of Public Health Policy at the Harvard T.H. Chan School of Public Health. We're also joined by Janet Rich-Edwards, who will moderate today's discussion. Janet is co-director of the science program here at Radcliffe, associate professor of medicine at Harvard Medical School, and associate professor in the Harvard Chan School Department of Epidemiology. Thank you to Maria, Dan, Sara, and Janet for being here. Finally, before our program gets underway, let me also acknowledge the members of the Radcliffe Institute Leadership Society and all our annual donors. Your generosity keeps Radcliffe events free and open to the public, and we thank you. Now, it's my pleasure to give the virtual floor to Janet Rich-Edwards.
Thank you very much for that introduction, Dean Brown-Nagin. Before we begin, as the moderator today, I'd like to give you a quick overview of the format for the program. First, we'll have brief remarks by Professor Sara Bleich, followed by remarks by María Belén Power, and then Professor Dan Carpenter. When they conclude their remarks, I'll moderate a conversation among the panelists for about 10 minutes. After that, the group will respond to questions from the audience for the remainder of the program. We encourage those watching today to use the Q&A feature on Zoom at the bottom of your screen to submit your questions at any time throughout the program, and we'll respond to as many as we can. And now I'll turn it over to Sara Bleich.
Hi, good afternoon. Thank you, Janet, and thank you, Tamiko and the Radcliffe Institute for hosting this really important panel. I come at this topic from a public health perspective, and will give you my take on what I think is some of the key things that need to happen to improve public health when it comes to equitable readiness. But before I do that, I first just want to give a sense of where we are when it comes to the public sector. Next slide, please. And so when we think about the public sector, we can think of it as a US safety net. It consists of many programs. There are dozens of them that are designed to help low-income populations. And to put low-income in context, for a family of 4, living below the poverty level is less than $26,200 per year. And so right now we think about the safety net. It's used by about 1 in 5 Americans and about 1 in 3 children. And when we just zoom in on low-income populations, it's about 3 out of 4 that are taking advantage of at least one of these safety net programs. So it touches a lot of Americans. Next slide, please. Now, if we look at how much the federal government is paying for the various safety net programs, what this slide is showing you are what's called outlays, which essentially are payments for different programs. These are estimated for fiscal year 2021 across the various buckets of the social safety net. So you starting from the top, you have food, housing, education, cash aid, and healthcare. Now, out of the roughly $4.4 trillion that were spent in fiscal year 2019, about a third of that went to the safety net. Next slide, please. And so you won't be surprised to hear that prior to COVID-19 ever happening, both poverty and food insecurity were persistent problems in the US. Poverty affected about 1 out of 10 Americans, and food insecurity, which is lack of reliable access to nutritious food, also affected about 1 out of 10 Americans. Both of these are expected to rise significantly because of the COVID-19 crisis. And both of these have significant impacts on well-being. Next slide, please. And so if we look at the negative impact of poverty on well-being, what we know is that if you're a low-income American, you face greater barriers in accessing medical care. You have higher rates of behavioral risk factors. If you live in a low-income community, you're more likely to face structural challenges that contribute to higher rates of disease, things like violence, material deprivation, or discrimination. And to put the impact of income in context, a middle-aged American in the top fifth of the income distribution can expect to live 13 years longer than the middle-aged American in the bottom fifth of the income distribution. So poverty impacts longevity. Next slide, please. We also know that food insecurity, again, that's a lack of reliable access to nutritious food, also has an impact on well-being. That refers for adults and kids to physical well-being. It's also psychological well-being. And in the case of kids, food insecurity can actually lead to poor academic performance. Next slide, please. So one of the things that you're probably well aware of is that as a result of COVID-19, there has been massive unemployment. And so what this graph is showing you is unemployment leading up to COVID-19. As you probably remember, unemployment was at an all-time low. And then starting in mid-March, when all around the country, schools and businesses started closing, unemployment skyrocketed. It is now at 15%. It is expected to get up to 20%, which is much higher than what was seen during the Great Recession. This impact of unemployment is going to greatly strain the public sector and is going to really increase poverty. And so that means that the social safety net is going to become ever more important during this time. Next slide, please. And so even though we spend huge amounts of money on the public sector, even though it touches millions and millions of Americans, there are many that argue that the public sector safety net is simply not adequate. And so from a public health perspective, the largest program that we often look to for helping low-income Americans when it comes to nutrition is called the Supplemental Nutrition Assistance Program. You may know it as food stamps, and the Supplemental Nutrition Assistance Program stands for SNAP. It helps about 38 million Americans afford food each month. About half of them are children. But the problem is that about 80% of those monthly funds are spent within the first 2 weeks. And so many, many families are running out of money to buy food. If you look outside of public health and you look into other social safety net sectors, we in the United States have no guarantees for affordable housing, no guarantees for childcare. And even though we've had a lot of health reform recently, there is no guaranteed reliable access to healthcare for all Americans. It's also the case, if you look to education, that the cost of education is highest in the United States relative to the rest of the developing world. And that's despite the fact that we have our investment in public education has decreased over time. Next slide, please. And so if we think about pro-equity policies, essentially policies that equalize opportunity, they can really help to address rising inequality, which is quite stark in the United States. We know that health is tightly linked to income, and we know that income is strongly influenced by public policies. And so if we have these pro-equity policies in place, or policies that are, again, equalizing opportunity, those can help in general, but they can also help in times of crisis like we're experiencing now, because it makes the government's ability to respond swiftly that much easier. Next slide, please. And so one thing we have seen is that during the COVID-19 crisis, the strain on the the public sector safety net has revealed a lot of opportunities. And it is through those opportunities that we have a chance to try to create more equitable readiness within the public sector. And you're going to hear about lots of different things on this panel from different perspectives about ways that we can go about doing this. And I'm going to offer you one from a public health perspective. So next slide, please. So if I could wave my magic wand and do one single thing to try to improve public health with respect to the public sector in times of crisis and in general, I would increase the size of the benefit that people receive from the SNAP program. Again, SNAP, you can think of it as, it's formerly the food stamp program. It helps 38 million Americans each month afford food. About half of them are children. There's a huge body of evidence which suggests that for families on SNAP, it reduces their food insecurity by about 30%. It lifts families out of poverty. So in fiscal year 2018, it lifted about 3 million Americans out of poverty. However, the current SNAP benefit is not big enough. We just talked about the fact that about 80% of families are spending all of their money about 2 weeks into the month, meaning that for those last 2 weeks, they don't have enough money to spend. And so a lot of advocates and policymakers have been calling for an increase in the size of the SNAP benefit. And what you hear most these days is a 15% increase. That was actually included in the HEROES bill that passed in the House on May 15th and will go to the Senate sometime in June. Now, I will say that the House and the Senate are very far apart when it comes to this possible fourth stimulus package. So it remains to be seen if the SNAP increase will stay in there. But I would say that if it were to happen, either on a temporary basis or permanently, it would represent a really important change to the public sector that would really help with equitable readiness going forward. So let me stop there and I'll turn the mic over to María Belén. Thank you.
Thank you, Sarah. Thank you for having this conversation and for inviting me. My name is María Belén Power, and you may not know me, but I know that we are connected through a river and a community that I call home. Road salt, home heating fuel, fresh produce. If you've ever wondered where those come from, well, at one point they were stored on the banks of the Chelsea Creek and along the rest of our community. Next slide, please. Chelsea is the smallest and second most densely populated city in the Commonwealth. At just 1.8 square miles, Chelsea has over 45,000 residents, 73% of which identify as a racial or ethnic minority, the majority of which are Latino and Latina like myself, who came here from Nicaragua. 24% live below the poverty level. In neighboring East Boston, there are 55,000 residents who live in 5 square miles, 3 of which are occupied by Logan International Airport. 53% of East Boston residents identify as Latino and Latina, and 17% live below the poverty level. Next slide, please. GreenRoots is a resident-led organization working to engage the most vulnerable populations, empower them to become strong leaders, so together we can implement innovative projects and campaigns to improve our public health and our quality of life. Next slide, please. Our communities are providing some of the largest regional benefits, while we shoulder the burden for air, land, water, and noise pollution from these very same industrial activities. Next slide, please. 100% of the jet fuel used at Logan International Airport is stored on the banks of the Chelsea Creek. 70 to 80% of the region's home heating fuel are also stored on the banks of the Chelsea Creek. Next slide, please. 400,000 tons of road salt that are used in over 350 communities in the Northeast are stored along the banks of the Chelsea Creek. Next slide, please. Chelsea is also home to one of the largest produce distribution centers in the country, serving the Northeast, the Mid-Atlantic states, and Southern Canadian provinces, bringing thousands of trucks in and out of our community daily. Next slide, please. Massachusetts, despite its progressive reputation, when it comes to public health, has some of the most profound race and class disparities. In 2016, the Center for Effective Government graded Massachusetts and only one other state an F for exposing people of color and residents living below the poverty level to hazardous facilities. Our communities have some of the highest rates of strokes, cardiovascular disease, and asthma hospitalization in the state. Now, we could sit back and allow these disparities to happen, or we can organize to create change. And we've chosen the latter and have had some pretty amazing victories. Next slide, please. COVID-19 has disproportionately impacted low-income communities and communities of color across the country. In Massachusetts, Chelsea has been the hardest hit by the virus. We have the highest rate of infection. In fact, it's 6 times higher than the state average. We know that this is in large part due to our environmental burdens and social determinants of health, such as safe and stable housing, access to public transit, food security, and others. While our community has been hit the hardest, our city and community partners have responded in an incredible way. In housing, the city has invested over $1 million in rental assistance to our most vulnerable residents. In food, the city is providing over 5,000 boxes of food per week. In medical and physical isolation, the city is spending $600,000 each month in hotel expenses to provide isolation for those residents with COVID-19 who cannot safely isolate. These are just some of the examples of how the public sector has really stepped up in our community in response to the pandemic. And it has really redefined the role of government. Now I will turn it over to Dan. Thank you.
Greetings, everybody. I'm privileged and honored to follow Sara and María Belén to discuss where we are in the response to COVID-19 and where we're going. I want to focus on what Sara and María Belén talked about as the public sector. And if there's a single message I have today, it's that the public sector is people. It's inseparable from the hiring that government does, and that all of our society relies at some level upon public sector hiring. Let me go to the first slide, please. If you look at one of the reasons why we in the United States have been caught flat-footed by the COVID-19 crisis in comparison, say, to a place like South Korea, where there has been massive tracing, massive contact tracing and testing, as well as quarantine, and they've successfully kept the public health damage much lower on a per capita basis than the United States has. In many respects, it's in part because we, compared to some of these other countries, as a nation, have underinvested in public health. And that means we've underinvested in the kinds of things that Sara and María Belén talked about, but also in the basic levels of government workforce and government agencies at the state and local level. Just since 2008, there's been a net loss of 55,000 local health department jobs since the Great Recession. If you look at the larger deficit going back to, say, the 1970s, what we've lost and what we could hire to meet need, we're talking about 250,000 public health workers. What would these people do? Well, they would be able to test, trace, administer vaccines and treatment, and they'd be able to do so especially for poor people, people of color, and rural citizens. In other words, that loss of local health department jobs is not evenly distributed across our landscape. It hits communities of color, poorer communities, and many rural communities disproportionately. One of the places you see this is in the decline in public hospitals. In 1970, not controlling for population, we had 718 public hospitals in the United States. As of 2010, we were down to 426. Right? That's a decline of about 60%, 40%. And it's important to understand that the hospital sector has been transformed in recent years, and that many older hospitals, public as well as private, as well as nonprofit, used to operate in a manner that was less efficient. But in some respects, what we did is we threw out the baby with the bathwater in getting rid of these public hospitals. Public hospital and clinic capacity and public system capacity grew in areas that were wealthier, and it progressively retracted in areas that were poor and characterized by people of color. Next slide, please. So one thing to think about in light of our twin crisis of public health and employment is the work that could be done, if you will, in killing two birds with a stone, in public hiring for public health that would also provide employment benefits. And I want to sketch out some of those possibilities for you now. If you were to examine the possibility of hiring hundreds of thousands of public health workers just to respond to COVID-19, not to say anything of all the other health crises that our nation faces, you could go after the identification of infected and diseased individuals. We could perform contract tracing and further testing of individuals like they're doing in South Korea. Isolation of cases and quarantine of close contacts. Some of this is occurring now, but not systematically. The administration and distribution of treatments and personal protective equipment. And we could also employ people to do epidemiological work, data analysis and mapping, not only for COVID-19, but for the kinds of environmental threats that María Belén talked about. Next slide, please. But then if we thought even bigger, and we thought about, well, what if we had a public health sector that looked more like it did in the 1960s and 1970s? And we thought about the larger context to come. Another coronavirus might come, another disease might come. We could think about a world in which many analysts suggest that we could create 1 million to 1.5 million more jobs on a nationwide scale if we invested more readily in public health preparedness. We could invest more heavily in our national stockpiles, including the ventilators that so many people have talked about and our vaccines, not just the manufacture, but critically the maintenance of those stockpiles. The CEO of Cleveland Clinic, Toby Cosgrove, and the CEO of CareCentrix, Don Driscoll, have talked about a 1 million-person healthcare ready reserve, possibly trained by the US Army or the Public Health Service. And we could talk about the creation and staffing of public health clinics to provide services formerly provided by all those hundreds of city and public hospitals, especially in urban areas, that have disappeared over the last few decades. Next slide. One of the economic benefits of government job creation is that it would assist and build our middle class. Among the many, many reasons that the middle class has declined in the United States is in part because government jobs have declined in a number of areas. These jobs are more stable, they provide benefits, there's the potential of an employment guarantee, they support middle class incomes, and there's also an easier allocation of jobs to tackle the kinds of long-term public goods problems for which the profit motive is less compelling. And here I'm pointing to the really important and leading research of two individuals, Derek Hamilton, an economist at Ohio State, and Paulina Chernova, an economist at Bard College, who've talked about and done a lot of research on the economic benefits of government job creation. And I'll conclude with this final slide, that I think at some level, there's only one way out of the COVID-19 economic crisis, which is the same way at some level out of the COVID-19 health crisis, which is a public sector investment that creates a more ready and equitable society. And Professor Hamilton and I have recently penned a white paper and an op-ed in Slate examining the possibility of a federal jobs program. Public health hiring would only be a part of that much larger program, but it would be a very important part. If we could provide 100,000, a million and a half jobs, we would produce benefits that were not only economic and not only had feedback through our economy, but also resounding and far-flung health benefits. Thank you, and that concludes my presentation. I turn it back over to Janet Rich-Edwards.
Thank you very much for three really informative and ranging presentations. So I'm going to open up now to a 10-minute conversation amongst the panelists. While I'm doing that, I encourage you to take advantage of that Q&A button at the bottom of your screen to submit questions but that we'll get to in about 10 minutes. So thank you all very much for that. I'm really interested in exploring how you see the short-term crisis response, this moment that we're in right now. María Belén, for example, talked about the provision of hotel rooms for people who are sick and cannot self-isolate. Sara, you talked about how provision of SNAP benefits during the crisis would be a benefit. And Dan, you talked about how we might marshal a greater public health response and workforce during the crisis. I'd be interested from each of you how you see this translating into longer term infrastructure. Is this a moment we can leverage for more future support as well as support during the crisis? I see Dan nodding.
I'm going to wait for Sara and María Belén.
Yeah, I would actually like to speak about the food piece, because food has been we've always known that Chelsea was a food desert. We've always known that we've had food insecurity. But COVID-19, like it was mentioned, it just has exposed a lot of those inequities. And now folks that didn't see that before are realizing the real need of food and the real issue of hunger and food insecurity in our community. And so I think that I guess my hope is that we transition from providing food at food pantries and delivering these boxes that we've been able to coordinate with the National Guard and the city of Chelsea, that we're able to transition into a robust system that includes more people, that addresses issues such as the public charge and immigrant populations, and that we are able to systematically provide food security to all residents, to the most vulnerable, to the undocumented, to the poor, to those living below the poverty level. So that's my hope as we transition from an emergency response to the pandemic to more systemic changes in addressing food insecurity.
And I would say, thinking about also picking up on this idea of food, and it is really striking with this epidemic how after we put health aside, like food is the primary concern for so many Americans because they simply are running out of money, or they're going to stores and they can't find food. And so one of the reasons why creating an infrastructure is so important is because if you, for example, are on SNAP, you have what's called an EBT card. You can think of it as a debit card. And that card gets loaded with money every month. You can take it to about 250,000 authorized stores around the country. In some ways, it's very easy for the government to just quickly load more money on those cards. And some of that is happening right now, but it is not increasing the overall benefit. And so if programs like SNAP are expanded, if the size of the benefit is increased, then in the long term, if we face another crisis, and the expectation is we will face another crisis with COVID-19, not to mention lots of other climate issues and other health disasters that may come, it becomes very easy then for the government to swiftly respond and put money in the hands of people that need it. And as a result, get food in the hands of people that need it. And the final point that I'll say is, there's no question that COVID-19 has had a massive social toll and a massive economic toll. But I think the silver lining in this is that it may pave the way for some really important pro-equity policies that will help low-income Americans for many years to come.
I would just say I agree with everything that Sara and María Belén mentioned. And I will emphasize again, I think that there's a role for the public sector to play, not only by doing the necessary work of providing benefits directly to citizens, but also by employing more of them. If you look at the crisis that has unfolded in unemployment, we now have, I think as of today, over the last 2 months, 40 million new unemployment claims, initial filings that have been recorded. And in many cases, state unemployment insurance is not available to individuals because those state level agencies are understaffed and overwhelmed by the claims. There are other organizational features that are blunting state level responses. But as we move forward, we need to, again, invest in the kind of public sector that can meet these challenges much more readily and much more equitably than we've seen to date.
Thank you. So another question is, at what level of government would we like to see response and, and basically sort of level of control over resources that might come out as a result of this crisis? I'm thinking in particular of the fact there are governors who have turned down federal support for programs like the ACA, turning down free money, sometimes for ideologic reasons. Is there a chance we'll be seeing some of that during COVID? And where would you therefore like to see our response emanate from?
I'll speak at first. The federalist system has its weaknesses and its benefits. One of the reasons I think that the federal government needs to step in, at least with funding for many of the ideas that the three of us are talking about, is that states and localities don't exactly have the fiscal tools that the federal government has, including the income tax capacity, customs capacity, and really nothing like the Federal Reserve that can sort of backstop government debt at the state level in the same way that the Federal Reserve can backstop it at the national level. And so at the very least, at the level of funding, I believe that the federal government absolutely has to play a role. And one of the things that Professor Hamilton and I have called for, both in the public health sector and not, is for the federal government to provide many of the jobs that we're talking about that are made available to state and local governments, but as federal jobs. And that means that the federal government essentially gets to set the terms of hiring and of bargaining of those employees, which blunts some of the ideological refusal of the states that you just mentioned, Janet.
Yeah.
And I would just add to that. So it's certainly the case that states all around the country are facing enormous resource gaps right now. And so if dollars are flowing from the federal government, and we're seeing more and more of that to help states and localities, then what becomes important is that a lot of that decision-making happen at a more local level, either at the state level or more local. If you just take María Belén's presentation, if you're just looking at Massachusetts, you're missing out on how Chelsea is an example of an area where there needs to be a lot more targeted funds. And so the policy making to really have an impact needs to be hyper-local, but the resources are going to have to flow from the top down.
I would just agree with that and highlight the role that immigration policies have and issues such as charge and fears that our community members and our immigrant community members have. In particular, when a president may do a policy and 4 years later a president may undo a policy, and so you never know whether you can trust the federal government. In fact, you do know that you cannot trust the federal government if you are an immigrant, if you are a mixed status family, if you are undocumented. Even if you're doing everything in the right way, you are fearful of accessing those resources. So I agree that the resources need to flow from the federal government, but there needs to be a local authority and management of those resources in the implementation phase.
Great, thank you so much. So I think it's time to open up to audience questions, which you can submit through that Q&A box at the bottom. Back in 5th grade, I took a speed reading course, one of those Evelyn Wood speed reading courses. So I'm going to be reading and skimming your questions that you're giving us quite quickly. Do me a big favor and keep them short and keep them as questions. And I'm more likely to be able to get more of them in. All right, so looking at your questions now. Here's one. How has the COVID-19 impacted the about 24 million Americans who live in food deserts? And how would SNAP help those people in particular?
Yeah, so I can take that. So a food desert is essentially an area where you don't have much access to food. So maybe there are a few supermarkets from where you can actually purchase food. So this actually has big implications for some urban areas and for rural areas. So what can SNAP do? So one thing that's happening very quickly in SNAP is that SNAP benefits are being authorized for use online. So historically, you could only use SNAP in the store. Again, it's like a debit card when you go. Right before this crisis started, 2 states were authorized to allow recipients to use their benefits online. That number is now up to about a dozen states have been authorized. And so those programs are rolling out quickly. And that happens through big retailers like Amazon and Walmart. And so what that means is that it creates much faster access for families to get food. But that's not going to be enough for areas where you don't have online access, or you go to the store and there aren't enough supplies there. There are going to have to be other resources that come into play to help families. But definitely SNAP is going to be the most effective, fast way to get people benefits and then to get people food.
So another question coming in. Why has public health been so overlooked and under-resourced in the US? And how do we address this bias against investment? Do we need some sort of renaming or rebranding of this aspect of community and government?
So I could also take that one, Janet. So I think that one of the biggest challenges that public health has is so much of what we do in public health is prevention. And so if we do our jobs well, you are not getting sick. You are having fewer road traffic accidents, cancer rates are down, obesity levels are down. But that's a harder sell from a public health perspective. What's a much easier sell is, more acute things like, changes to the hospital system that are helping people immediately when they get disease. And so I think one of the big challenges that public health has is a marketing challenge, because we're always sort of spinning this counterfactual. Well, if we don't prevent, then this is what could happen. And that can just be a tougher sell. I 100% agree with the person that asked that question. We need more investment in public health. And part of that is simply telling the story of why public health has such a significant impact on our lives and across so many sectors. And importantly, how if you improve public health, you're not just adding benefits there, you're also improving education. You're also improving other major social determinants of health that can have ripple effects across the economy.
I just want to echo what Sara said there. I think it's worth pointing out, look, we live in a polarized world right now in the United States especially. But I think our politics are moving as we speak, as we have this seminar. And I don't necessarily just mean our partisan politics. I think Americans across the age distribution, across our country, are witnessing right now, again, what I'll call the flat-footed response that we as a country had to this crisis compared to that of, say, Canada, compared to that of, say, places like South Korea and others. And there is going to be an appetite for thinking about, solutions in the future. Some of that may come through electoral change, but, who would have predicted that, a Republican Senate and a Republican president would have signed on to trillions of dollars of economic stimulus just 6 months ago. And so I think our politics is changing, and it will continue to change because coronavirus isn't going away. It's going to be back in the fall. Other viral infections will be back, and this public health crisis is going to remain with us. Is that by itself enough to change the dialogue? No, I agree with Sara and others that rebranding is needed. I think we need new storytelling. I think we need to understand that people need sort of a tangible and visible, a more evocative sense of what public health brings. And I think the way Sara put it, in terms of the lower likelihood of getting sick in the first place, is a great way to start that conversation.
I agree. And I would like to just add one more thing about the role that money has played in the US and in the public sector, a disinvestment in public services and a privatization of services that should be a public good, that should be managed by the public, that should be accountable to the residents and to the voters. I think the narrative matters. And I also think that the role that corporations and money has played in policymaking is really defining who we prioritize and who is served and who is not served. And I think that we need to shift the way we see the role of government and the role of these public services and the role of such critical services like public health, like public transit, like housing, and really take out, remove the role of money and the role that corporations have played in the decision-making process.
Thank you for that. We're getting a lot of questions about how we would pay for this. Some saying, the likelihood of reducing military spending or increasing taxes doesn't seem likely to occur anytime in the near future. So how do we imagine we would pay for this new, stronger, more robust infrastructure?
I'll start off. I think it might be in the very near term that tax increases are not likely as we suffer through the worst of this crisis. But I do think larger income taxes are coming in our country, and probably those imposed at marginal rates on higher incomes. For those who think it's impossible to have a robust public sector, for those who think it's impossible to have a tax infrastructure that is more equitable, let's just go back to the 1950s in this country, which in many respects was a conservative decade, where we had a top marginal tax rate of over 90% on the highest level of incomes. And we had a sweeping, still discriminatory, still problematic, far from perfect, but a sweeping public health system at the local and the local and state levels. We had, dozens of public hospitals and clinics in Detroit. There are now 4. We had all sorts throughout the Midwest, our major cities. And so the landscape in the not too distant past, an American past, looked not too dissimilar from the one that we're probably going to have to recreate in the years to come.
Yeah, good. We've got a lot of historians in our audience, and many people making comparisons to the CCC and to the New Deal, and asking about should this be phrased as put in the context of a Green New Deal. Any thoughts on, where have we, about the historical transitions that brought us, for example, Social Security? Is this a crisis similar to, say, the Second World War that we might come out of? Can we look to and gain new traction? Can we look to history to inspire us how to make this happen now?
I'm happy to just, given that I've written recently on this, I'm happy to jump in. I guess I would say what we know about the New Deal are 2 things. First, the New Deal, from economic research that's done by people like economic historians like Price Fishback, we know that some of the most durable effects of the New Deal actually came through its public sector hiring programs. That's where the long-term income and income stability effects of the New Deal, particularly in rural areas, but also in many urban areas, happened, not just through the provision of unemployment insurance, but through things like the CCC, the Works Progress Administration, things like that. And the second thing that we know is that, there's often a story that say, well, it wasn't really the New Deal that, solved the Great Depression, it was World War II. Well, yes and no. The New Deal itself made a difference, but the reason that World War II made a difference was in part because it was a massive public sector hiring program in the military sector, but also the civilian sector, things like that. And so, the lessons of history here seem to me to be that large-scale interventions like this are possible. Nobody is saying that we need to recreate our government as it was in the 1940s and 1950s. The New Deal was very racially discriminatory. It left out people of color. Professor Hamilton and I are, for instance, not calling for the recreation of something that existed before. We can do better. And we can do all of this, I think, by respecting our federalist system, because we can't always rely on the federal government, as María Belén noted. We do need local government, which is often more responsible. But where we do need the federal government is in the provision of resources, because local and state governments don't have the fiscal capacity that the federal government has. And that's just the reality, and that's going to stay with us for quite some time.
And I would add to that from a not too far distant historical perspective, hunger has for a long time been a bipartisan issue. And so it is something where Republicans and Democrats often reach across the aisle. That is what helped create the formerly food stamp, now SNAP program in the first place. And it's my hope that it's through that sort of bipartisan support for Americans should not go hungry that will push forward more legislation in the fourth stimulus bill that will hopefully come in June to increase, for example, the size of the SNAP benefit. The other thing we know from the Great Recession is a lot of policy approaches, some of which we're talking about now and many others, have been tried already during the Great Recession. And so we have a lot of evidence from there. It's not really historical, but we have a lot of evidence from there about what does and does not work. And that can be leveraged now and into the future to think about when you have these acute situations specifically, but more generally, how do you improve the infrastructure so that we don't find ourselves in the situation that we are in now, which is a lot of people that need help are falling through the cracks because the safety net is not sufficient enough to help them.
María Belén, a question particularly for you. How do we effectively get the voice of those most affected to help shape policy and solutions?
Thank you. I think, one of the things that we have talked about with COVID-19 is that grassroots organizations and environmental justice communities, which is defined by race, class, and language isolation, we have been doing the hard work of organizing and fighting these hazardous facilities and fighting power plants in communities of color. And I think if there's one lesson that we can take from this crisis is to really listen to the folks on the ground. We have been begging, asking, organizing, and fighting for environmental justice legislation at the state level in Massachusetts, and we have been ignored. And environmental justice legislation would have protected our communities. It would have prevented a lot of the damage that has happened. And not only in Chelsea, but in Black and Brown communities across the country. And so if there's one lesson is that the most impacted communities have to be at the decision-making table from the very beginning. And like our Congresswoman Ayanna Pressley says, those that are hurting the most need to be closest to the power. And so we can't continue the old way of making policies and making decisions for vulnerable communities. We in the grassroots, we in environmental justice communities, we have the solutions for these policies that will improve and affect our quality of life.
Very good. Lots of questions coming in too about the role of industry and corporations, how they might be incented to lobby for investment in public health, and if so, how, and in particular, Amazon. Any thoughts about that? Is there a role for industry in this, and what might that be?
So I could start trying to take that question. So if we think about the public health nutrition space, large companies like Amazon have jumped into that space. So I mentioned earlier on that SNAP now allows some participants to use their benefits online. And so Amazon was one of a handful of different retailers that was authorized a couple of years ago to begin offering those benefits. Now, from the Amazon perspective, that is opening up a market that they didn't previously have access to. But from a public health perspective, that is creating access, particularly food access, for people that didn't have it. And so in my mind, the sweet spot is identifying ways that industry can advance their fiduciary responsibility to shareholders, while at the same time leveraging ways to improve the public's health. And I would imagine there's lots of scenarios where that could happen, not just in the Amazon example, but across the private sector.
Yeah, let me add, Amazon is interesting. It's been in the news a lot lately, not simply because it's profiting massively from the redirection of commerce from in-person venues to online, but also because we've come to realize that in this debate over our postal system, Amazon itself actually depends very heavily upon our public sector. And one thing to keep in mind among the many proposals out there is an expansion of postal services in our country at the local level. The Postal Service is one of the most popular government agencies, right near the top, especially in rural areas, but also in urban areas. Just as recently as 1970 in this country, we actually used to have post offices that doubled as savings institutions, not as full commercial banks, but as basically savings banks with the ability to open small savings accounts. And there's been a lot of discussion about basically using the infrastructure of the Postal Service to leverage that infrastructure to open different kinds of clinics that would be available, things like that, really across the country. So I want to emphasize that I don't think that there's always a tension or an irreconcilable tension between the interests of corporations and the larger imperative here that we're talking about for public sector investment. My guess is, yeah, I think where the rubber really meets the road here is probably in increased taxation rates, especially on those of higher incomes. But again, I think we're probably headed there anyway, not simply because of the debt that we're accumulating as a country. This would be an opportunity, again, to create a society with that would share opportunity more widely. Would there be political opposition? Yes, to some of the tax increases, but I also think that that's not insuperable.
Another question is, how do we train this workforce? How does public health interface with education? And how would people get qualified? Some questions about how do you get qualified even to become a contact tracer, or what other kinds of public health workers would we need for this new infrastructure we envision?
This, Janet, is actually a nice transition from the last question, because one really key role that the private sector could play would be massive recruitment and training of people to work in the public sector. And that might happen more efficiently in the private sector, but it's certainly a challenge sort of finding everyone and training everyone up. But some of the facility and ease with doing that might sit outside the public sector, and there might be a nice partnership there that could really grease those wheels.
I agree completely. What Sarah's points to is the complementarity between public sector investment and private sector growth. Whether it's in contracting jobs, whether it's in education and training, there would be a feedback effect, and if you will, even a multiplier effect of public sector investment on the private sector. There are a lot of universities and schools in the nonprofit sector around the country that are going to have to reinvent themselves in the wake of the recession that we're enduring right now. Training people like contact tracing, training people in public health jobs would itself create jobs and would also contribute to a broader human capital formation among our workforce.
If I could just add one thing, the role that culturally competent community health workers is going to be key. And I think that the role of the private sector can really fill in that gap and ensuring that we are hiring culturally competent community health workers, but also that we have multilingual communication and that we are really ramping up a public health sector that is outreaching to everybody, not just low income and communities of color, but to really everybody, because that is really going to be the benefit to the public health sector, including the multilingual, the culturally competent, and addressing all of the barriers that we have seen played out.
And if I could, Janet, just add one more point here. One of the reasons why we are having this session is we care about having a more equitable public health sector because we have so many inequities right now. And if it's the case that things like contact tracing and other key things specific to COVID-19 happen only on a local level, then that has the potential to just exacerbate existing disparities if everyone doesn't have equal opportunity to get access to those resources. And that's where having the funding, tying back to the earlier question, having that funding flow from the federal government down to the organizations that can implement it becomes important, because if it's universally implemented, at the very least, then everyone should have access to those resources.
Well, thank you. And thank all three of you. This has really been food for thought. I, for one, am encouraged by your passion and your ideas about how we might use this crisis, not only to meet the challenges of today, but to build it so we can prevent some of the same issues from arising and to have more equitable infrastructure and access to healthcare and work throughout the country. So I want to thank you for participating in the program today and for the important work you do every day. I also want to thank our audience. These were really terrific questions, and I'm sorry we couldn't get to every last one of them. Our time has run out. I hope you will be able to join us for future virtual programs from Radcliffe, which include Naming Racism, COVID-19 and Beyond, on Thursday, June 4th at 4 o'clock, and When Stay at Home Isn't Safe, Domestic Violence During COVID-19, which will happen on Monday, June 8th at 1 p.m. Further information about these programs and others can be found on Radcliffe's website, radcliffe.harvard.edu. We hope to see you then. Have a good afternoon, everyone. Bye.